Okay, guys, so today we will be discussing evidence-based dentistry. We have heard a lot about the evidence-based medicine, evidence-based practice. Today we will see how this evidence-based practice is being incorporated into the dentistry. First of all, let's see what is evidence-based medicine. Evidence-based medicine is defined as integration of the best research evidence with clinical expertise and patient values. An extension of EBM that is more relevant today is evidence-based clinical practice, which considers the healthcare setting and circumstances in which we practice. Evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of the modern best evidence in making the decisions about the care of the individual patient. Evidence-based medicine, or EBM, whatever you call it, integrates clinical experience and patient values with the best available research information. Well, in their clinical practice, dentists need to make clinical decisions based on the limited scientific evidence. The goal of evidence-based dentistry is to help practitioners provide their patients with optimal care. And that is going to be achieved by integrating sound research evidence with personal clinical expertise and patient values to determine the best course of treatment. Evidence-based dentistry is the integration and interpretation of the available current research evidence combined with personal experience. This allows dentists as well as the academic researchers to keep abreast of new developments and to make decisions that should improve their clinical practice. According to American Dental Association, evidence-based dentistry has been defined as an approach to oral health care that requires the judicious integration of the systematic assessment of clinically relevant scientific evidence relating to the patient's oral and medical condition and history, together with the dentist's clinical expertise and the patient's treatment needs as well as preferences. Like, patient is in need of getting a replacement of the tooth. So whether patient is preferring to have a removable partial denture or a fixed partial denture or maybe an implant, patient's preferences also valued. The evidence-based medicine movement, it was started in 1981 when a group of clinical epidemiologists at McMaster University in Hamilton, Canada, which was led by David Sackett. They published the first of a series of articles in the Canadian Medical Association Journal advising physicians how to appraise the medical literature. The actual term evidence-based medicine was first coined by Gordon Guyatt. He was the program director of internal medicine at McMaster University from the year 1990 to year 1997. He was one of the Sackett's mentees in 1991. In 1976, actually, as a result of a joint effort of the deputy health ministers across the 10 Canadian provinces, levels of evidence, which they call LOE, it was introduced by the Canadian Task Force on Periodic Health Examination. The mandate of the task force in its first 3 years was to establish the methodology for evaluating the scientific evidence. This task force proposed an evidence rating system, and how it was done. It was graded on the 1 up to 3 levels. So grade 1 is obtained from at least one randomized controlled trial. 1 is the highest level of evidence, 3 is the lowest level of evidence. Randomized controlled trial, it is graded as number 1. Obtained from well-designed cohort or case control analytic studies, preferably from more than one center, that is going to be considered level 2, 1. Obtained from comparisons between time or places with or without intervention or dramatic results in uncontrolled experiments, that is considered as level 2, 2. Well, the opinions of respected authorities which they may be presenting during some conferences, through some posters, or maybe through the letters to the editors, they were based on clinical experience, descriptive studies, or reports from the expert committees, or even a series of uh, certain cases. So that was graded as level 3. These did not have any like very solid, or you can say very good grounds for the solid footing. That early LOE system was improved by Professor David Sackett. Since then, a more stringent and elaborate system was introduced which specifies the conditions under which a study may be upgraded or downgraded depending on its methodological quality. So the relation between the levels of evidence and grades of recommendations by David Sackett, it is level 1, large randomized controlled trials, clear results, low risk of error, grade A. Level 2, small randomized controlled trials, uncertain results, moderate to high risk of errors, grade B. Grade B also contains level 3, non-randomized trials, contemporaneous controls. Then comes grade C, and it had level 4 and level 5. Level 4, non-randomized trials, historical controls, and level 5, case series without any control. So far, so good. Everybody is okay with the concepts? Yes, no, maybe. Randomized controlled trials and meta-analysis are always placed at the higher level for the evidence-based practice. Keep this thing in your mind. And case series, they are at the lowest level. So in case if they ask you a question, these things, these concepts should be in your mind. Evidence-based dentistry is progressively and quickly incorporated into the dental practice. Dental schools are integrating and those principles into their curriculum, and resources are becoming more widely available. Various countries have established centers for evidence-based dentistry, like the Center for Evidence-Based Dentistry in UK, then DSM Forsyth Center for the Evidence-Based Dentistry in United States, and the Cochrane collaboration. It also has an oral health group. Cochrane is actually a global independent network of researchers, professionals, patients, carers means caregivers, and people interested in health. And that is providing the resources, mostly those resources which are based, those articles which are based either on the meta-analysis or on randomized controlled trials. Why this evidence-based dentistry is required. Dentists graduating from the dental schools are up to date with the best practice in dentistry current at the time of their graduation. So whatever they learn, it is actually at the time when they are graduating. We are talking about North America. Back home, definitely we are lacking behind, and in certain subjects, we are being taught what our professors were being taught like in 1980s or 1990s. So we are talking about North America, or maybe in modern world, UK, Australia, New Zealand, most of the Europe, etc., etc. So they have the knowledge which is current and up to date. Over the period of time, some of this knowledge gradually becomes out of date with some fresh research and newer technology. It is important for dentists to be able to keep abreast with developments in diagnosis, prevention, and treatment of oral disease and newly discovered causes of disease for the betterment and safety of their patients. These advances in dentistry, these are usually, first of all, reported and published in the journals before they will come in the textbooks. And in order to keep up with new research, healthcare professionals need to feel confident that they can read and evaluate articles in the dental journal. How to practice the evidence-based dentistry. Evidence-based dentistry is built upon asking questions. These could arise in several ways. A new patient with some symptoms and you wish to treat them in a more effective way. So that is going to bring a challenge. And now you have to see how someone has dealt with such a similar situation. Is it reported, published, or if not, then are you going to be the first one to treat that type of patient? So how you are going to report that? Any relevant material is available, any relevant technique is available which you can employ. A patient needs some information regarding some advancement in the treatment or maybe about maintenance of their oral hygiene. They want to ask you, okay, doc, should I be doing flossing or should I be using the interdental brushes? Or they will ask you, okay, is it better to use the manual toothbrush or it is better to use the electric toothbrush? Like just a couple of days ago, someone messaged me and asked me, how do you rate the charcoal toothbrush? Should I use it or not? And that was definitely because usually people, they don't ask about these things, but definitely you have. So I had to do some research to find out what are the, because a couple of years ago, 2 to 3 years ago, the charcoal toothbrush was very popular, but now in like these 3 years, do we have some restrictions? Do we have some kind of further information? Or maybe after 3 years, they found out that it is not a very good thing to be used or not. So I had to do the research before I replied them. Or maybe there is some new hot topic, like a couple of years ago, everybody was giving the regular implant treatment, regular implant therapy. But all of a sudden, certain people who attended those courses, they started talking about all on four or all on six technique. So those who were not practicing or who haven't attended those conferences or workshops where all on four or all on six technique was being discussed, they had to find out the information. I will do it separately as a, like, it has some drawbacks. It does some a little bit of the abrasion on the enamel. That is a major drawback. Otherwise, everything is good. So I was telling you that when there is a new hot topic, or maybe like when I started practicing this orthodontics few decades ago, at that time, lingual orthodontics was also gaining popularity. And those courses, they were only being conducted in North America, nowhere in the Europe. So we had to find out either the books, or at that time even internet was not available, and we had to buy the books, we had to order the books, we had to find out the articles on it. And even at that time we were not sure that what we are doing, it is actually an evidence-based dentistry. But that's how we found out, and then we realized that this is not a very good technique for me, because probably I won't be able to do the justice, and as well as for my patients, because the type of food, uh, the meat and all that they eat, so it is not a very good idea. It's going to be debonded many times, and then they are going to have problem. Their tongue, their mucosa is going to be injured and all that. There are three components of the evidence-based dentistry. Basically, evidence-based dentistry is an approach to the oral health care, and it is a method to acquire, understand, and apply the most current scientific knowledge. So basically, when you have some problem, then you amalgamate the evidence, your clinical expertise, utilizing that technique, and the patient's preferences and needs. There are 5 steps of the evidence-based dental practice. First of all, recognize a need for information and formulate an answerable question. Ask, ask, ask. Then you are going to acquire the relevant knowledge about that. You have to find best evidence with which to answer that question. Look for systematic reviews, meta-analysis, and double-blind randomized controlled studies. Like one fine morning, I was doing my outdoor when I was an internee, and at that time we received a newborn baby with a huge mass in his palate. Maybe the child was 2 to 3 weeks old, and he had a huge mass in his mouth. Well, I was just taking the history and I was looking at him. My professor entered the room and he said, book this child for tomorrow. The child is having neuroectodermal tumor of infancy. Well, it was my professor. He said it. I had to book it without realizing what it is. But in the break, I went to the library, found out, first of all, I got the Schaefer, whether this name is existent or not. The name was there, but only 2 or 3 lines about the tumor, and it was there written that, or maybe 21 or 22 cases reported. So what we were going to operate the next morning was probably the 23rd or 24th case in the world. And then I found out Journal of Oral and Maxillofacial Surgery, somewhere in like published in the year 1988, 89. There was few articles on it. Then I found out in Journal of Oral Pathology a little bit information about it. But I had a clear picture, so that tomorrow when we will be working with the professor, at least I should be knowing that what we are dealing with. Making sense, yes or no? Then after acquiring the knowledge, you appraise it. Evaluate the evidence for its validity, reliability, relevance, and usefulness. How useful it? Like in 1991, it was a taboo to do single sitting root canal treatment. But we were having a lot many patients at that time, maybe because of they were getting more spore for maybe some other reasons, or maybe motorbike accidents or whatever. So usually maxillary central incisors fractured and they are coming to us. Their main concern was not root canal treatment. Their main concern was getting the smile better, so that the fractured incisor is not going to be visible anymore. They wanted that the moment they enter the dental office and when they leave it, everything will be perfectly fine. And that was in those days, as I told you, root canal treatment doing in single sitting was a taboo. Nobody was doing it. So I started searching, and finally, if you remember, I told you about how I developed my own technique, and I got award from Royal College of Surgeons England on my uh, published this what do you call it, poster in a poster competition, and I developed my own technique on that. So that's how you appraise. You find out, check whether the validity, like when I was looking at the study from Baylor College of Dentistry, they told that single sitting, they started doing single sitting RCTs, even in the multi-rooted teeth. And they said, like, when I waited out of like their cases, 90% was the success rate, and I thought that 90% is a very good success rate, and I will go with that. So I devised my own technique based on this information which I received. Then after appraising, we apply. We integrate the evidence with the clinical expertise and patient's needs. And then we act, evaluate the overall results and the process, make any necessary changes. Like if you remember, I told you how I changed the incision. I was not going for the typical uh, this Luque Oxenbien lesion, and I have modified it according to my need. And then again, the same cycle continues. Evidence-based dentistry, it is an ordered approach. The practice of evidence-based dentistry is relatively straightforward but requires an ordered approach. The 5 steps are summarized in this figure. Like, first of all, we identify the clinical problem. Dentists have to elicit, sift, and decide how to best use information gathered from patients, the literature, colleagues, and experts in the field. So they formulate clear questions, clarify the relevant outcomes, they search for the evidence. Some signs and symptoms may be unexplainable, some may be difficult to treat, or the patient may simply wish to discuss a treatment plan that has been recommended but about which they are uncertain. Now, while you are searching for the evidence, if any irrelevant or obsolete information comes in your way, ignore it. And interpret the relevant evidence. Then decide on the appropriate action based on the best evidence available. So understanding methodology makes the process easier, and approaching the problem logically results in an informed decision about the best way forward. Practicing evidence-based dentistry enhances patient safety and well-being. We talk a lot about the PICO format or PICO format, whatever. I pronounce it PICO, few people pronounce it PICO. First of all, identify the problem or disease of interest in a patient. So P is for problem or for the patient. Patient, population, or problem. What are the characteristics of the patient or population? what is the condition or disease you are interested in. Then the intervention or treatment in question, intervention or exposure, what do you want to do with this patient? For example, treat, diagnose, or observe, depending upon the requirement for that particular disease. Like say, for instance, we always say for gingival stomatitis, only and only supportive therapy is required. We are not going to give any antibiotics. We are not going to give any, what do you call it, steroids. Like some good 30 years ago, without realizing that it is going to worsen the situation, the practitioners, they were prescribing steroids for gingival stomatitis, but not anymore because we have evidence-based dentistry. Similarly, like some 20 years, 25 years ago, for any case we were performing root canal treatment, nowhere, like no matter anywhere in the world, antibiotics were being prescribed for 5 days, 7 days, 10 days, etc., etc., depending upon the size of radiolucency. But over the period of time, we realized that it is mere stupidity. You just remove the necrotic uh, part of the pulp, clean the tooth, and everything is going to be good. No need to give any antibiotic. It is based on the evidence, like this become possible because of the evidence-based dentistry. Then the comparison. What is the alternative to the intervention? Like I told you earlier, that at times patient's teeth are missing. Patient needs replacement. So what would be the alternatives? Whether very expensive implant treatment or a moderately expensive fixed prosthesis or a cheaper version of it, which is a removable partial denture. And then again, decide between the two, whether the plastic one or the cast partial denture, depending upon the future of the other teeth. The outcome through which the intervention and comparison treatments will be evaluated. What are the relevant outcomes? Means any morbidity, death, or any complications. So if we would have performed the other procedure, whether it was a better option or this was a better option. Where do you find this evidence on which you are going to perform your practice? Some of the best sources of evidence that are fast and easy to use are online resources like PubMed, Cochrane Library. You can also access journals either physically or online, textbooks, especially the latest editions. It is always a good thing to attend the conferences because certain new techniques, certain new uh, topics are being discussed in the conferences and people bring their some research work. Even visiting the table clinic area and visiting the poster area, it also gives you a lot of information about new things. Attending certain seminars or workshops, or maybe attending the continuing education programs. When we look at different types of uh, text and the, or you can say the written material available in the journals, so levels of evidence for preventive or therapeutic studies, from strong to weak to no evidence. Systematic review and meta-analysis, they are on top. They are the best. So if someone asks you a question that a lady who is pregnant and she has a periodontitis, chronic periodontitis, or maybe a gingival inflammation, and she has heard from somewhere that those ladies who are having perio condition and they are pregnant, more chances that they are going to have low birth weight of the baby. So they ask you, how will you satisfy? You will definitely guide them to consult the systematic review or go through some meta-analysis publications. Then comes the randomized controlled trials. Well, regarding certain medicines like ibuprofen is better or naproxen is better in a person who is a cardiac patient who is known having angina and is on anginal therapy. So in case you want to give a NSAID, which one you will go, definitely you will consult some published randomized controlled trials. We still consider those systematic reviews, they are on top, but gold standard is randomized controlled trials. Everybody is okay with these concepts? Yes, no, maybe. Then comes the case control studies. This is where not uh, like we cannot say that they are very good, but still we have some better evidence available from the case control studies. Then weak for the case series and case reports. Definitely, if someone has performed like a couple of years ago, maybe you can say 25 years ago, there was a dentist in Wichita Falls in USA. And because of the very high fluoride level in the water in Wichita Falls, that person was receiving a lot many cases of fluorosis. Well, in those days, one treatment option was definitely to go for the crowning and either porcelain fused to metal or you can go for the all ceramic crowns. That was the era when all ceramic crowns were still under development, and some of the dentists they have started performing the porcelain laminate veneers as well. But he devised his own technique according to the needs of the patient, not very expensive. And after doing a lot of cases, then he started publishing it in the Quintessence Journal of Practical Dentistry. I followed him and I also adopted that technique, that was micromechanical abrasion of enamel. He published so many cases. Definitely he was getting some results. That's why he was publishing, and his work was being published in one of the renowned journals. It means it carried some weightage, though no other comparison was there, but still like a decent amount of cases being presented every now and then by that guy in the case series regarding this problem and the remedy he devised. Making sense, yes or no? Then comes the case reports. As I told you, ideas, editorials, and opinions, they do not carry much of the weightage. So if you keep this pyramid in your mind, you would be able to answer many questions. Best evidence. The term best evidence really means the best available evidence based on this hierarchy of study design, which I have showed you. If higher levels of evidence are not available, that is systematic reviews or randomized clinical trials or controlled trials, then one must seek studies lower in the hierarchy while at the same time acknowledging the potential for increased bias. Like we have one question which is being asked multiple times, and that is females with undernourishment, they gave birth to low birth weight babies. But over here we have a bias. Certain girls who belong to good socioeconomic group, just they don't want to eat, they have, like, they grew up with bulimia and all other things, or doing dieting, or figure conscious type of ladies, they do not want to have good food, so their babies are also low birth weight. But on the other hand, we are having a universal problem, and that is low socioeconomic girls. They are undernourished because they cannot afford to have proper diet, and their babies are also low birth weight babies. Making sense? Yes, no, maybe. So here we have to check for the bias. The bias is there or not. In some instances, little more than expert opinion may be the best evidence currently available. Like, you are working in an environment where you have a professor, a mentor, and you are clueless. Should I go for this treatment or should I go for that treatment? Here, consulting with the consultant with more experience also considered as best evidence. Good. Systematic reviews. The systematic review is quickly surpassing or exceeding the traditional literature review as the preferred method for summarizing and synthesizing relevant research evidence. Advantages: providing clinically relevant information to aid in decision making, reducing the biases inherent in traditional literature reviews, and to follow strict protocols. If we look at the comparison of the two, traditional review not to be well focused on a specific problem, whereas systematic review is focused on a specific clinical question. Traditional review not including all of the relevant studies, whereas systematic review include all the relevant studies. Traditional review not combining the information from the studies, whereas systematic review will combine the information from these studies. Traditional review are subjective, whereas systematic review are objective. Systematic reviews we are discussing, narrower focus permits a much more careful and complete search and selection process to identify and include all relevant studies that have addressed the question of interest. Because the topic is limited, the number of articles that contain information is also usually quite limited so that their careful analysis is feasible. Systematic review is a scientific study that is guided by the development of a protocol that outlines all steps in the review process. There are not simple surveys of the, like these are, they are not the simple surveys of the literature. They are designed to minimize the bias. They require the prior determination of search methods, inclusion criteria, and evaluation criteria, which reduces the chance of bias in deciding what studies to include in evaluating the strength of those studies. Now, question is being asked, what is the difference between systematic review and meta-analysis? Both are on the peak of that pyramid. Now, how to differentiate between the two? A systematic review answers a defined research question by collecting and summarizing all empirical evidence that fits pre-specified eligibility criteria. Whereas a meta-analysis is the use of statistical methods to summarize the results of these studies. So if we look at the comparison, systematic reviews identify and critique relevant research studies, whereas meta-analysis identify relevant research studies using a defined protocol. The systematic reviews, they discuss factors that may explain the heterogeneity, whereas meta-analysis statistically test study heterogeneity and investigate explanatory variables. Systematic reviews synthesize the knowledge, whereas meta-analysis statistically summarize results to obtain an overall estimate of the treatment effect. Evidence-based dentistry and the clinical practice, how we have to integrate it. Using the evidence-based dentistry in clinical practice essentially involves identifying and using the best available scientific evidence in caring for patients. Evidence-based dentistry also incorporates the clinician's expertise and the individual patient's needs and personal preferences during treatment decision-making. These decisions are ultimately made by patient and are very personal, and thus they will vary from patient to patient. Assessing and using current best available evidence is at the forefront of the decision-making process. And if you know that some treatment is more beneficial, then it is criminal not to discuss it with your patient. So over here we are done with our this important lecture.